Burns could be accidental, they could be due to neglect, or they could be non-accidental. Neglect is a lot more common than a deliberately inflicted burn. Lots of things can burn children, or they can fall into a bathtub, flames, cigarettes, friction burns, chemical burns. Sites of burns, again, worrying places would be the face and the head, around the bottom. Backs of the hands are often burnt by cigarettes or feet. And I'm going to show you a picture here of forced immersion. That's the foot and the hand. And the telltale signs of these are there's a clear water demarcation line, which means a child has been held in the water, and there are no splash marks. So if a child falls into a bath, they're going to splash about, and they're going to have splash marks further distal to the burn, proximal, sorry, to the burn. This is a contact burn from an object, and again, you would want to have a very good explanation which is consistent with that. This picture is of a cigarette burn, tend to be circular. They are often a size between 1/2 to 1 centimetre. They're punched out in the middle. They may heal with scarring, and the differential diagnosis would be of impetigo or chicken pox if they're healed. Fractures in children, a lot of children will fracture by the time they're 16. 80% of abused children are those with under 18 months of age. Accidental fractures, most of them tend to occur older than 5 when they're running about and often unsupervised. So a baby less than 4 months is more likely to have been abused with fractures than have a medical cause for their fractures. These medical causes are rare. Abuse is common. Obviously, we want to know about the developmental stage. What's the child's mobility? So things that are concerning for abuse: humerus, twisting fractures, of the spiral fractures, rib fractures, fractures of the femur. Again, once they're up on their feet, they can twist and fracture their femur. But again, premobile children with femoral fractures are very worrying. Spinal fractures, metaphyseal, which is the pictures on the screen here, the growing ends of the bone. So if you're shaken or grabbed, you're going to fracture the ends of the bone, which are more fragile. Skull fractures are equally likely to be, in young children, abusive or accidental, and can be hard to distinguish between them. They also can't be aged. This is a diagram to show you what happens when an infant is shaken. They can fracture on the internal surface of the ribs, so there may be no bruising. The child will be very distressed at the time, but may not show a lot of distress later. They will take up to 2 weeks to become visible on X-ray by callus. And that slide there, there's just a lot of different causes for fractures. There's a lot of nutritional issues, genetic issues. We will think of all these things when we're thinking about fractures. We had a case recently of multiple rib fractures in a baby, but very quickly on skeletal survey, they were found to have other bony abnormalities. So often there will be other bony problems seen on the other x-rays. And this is what we're about preventing. We want to prevent abusive head trauma in children, in infants, because it is a cause of death. So how are they going to present? Well, if you have a child who comes into ED and they have a swelling on their head, is there a fracture underneath that? Is there a bleed? Is there an internal intracranial bleed? So you might have evidence of shaking. So we don't tend to use this phrase in reports, but it's useful to think of the constellation. So little diagram there is showing retinal hemorrhages. If a child is shaken, they will often have a subdural bleed. They will have retinal hemorrhages, and they may have some form of brain damage or encephalopathy. There's often an inappropriate or inconsistent history. They often have other apparently inflicted injuries like rib fractures, little fingertip bruises on the chest or elsewhere, and the metaphyseal fractures from being shaken. How do they present? Well, there'll be a decreased responsiveness. They become irritable. They then become maybe lethargic or limp. They have an episode where they stop breathing, usually because there's been shearing of their upper cervical spine and brainstem. They may have a focal seizure, so jerking of one side of the body or one side of the face. They may then go on to vomiting. They then develop their Cushing's response as their brain is subject to increasing pressure, and they end up maybe needing to be intubated and go to ICU. So we have to particularly think of this as a possibility in infants that come in who are very irritable, who are presenting with an apneic episode or a seizure, as that is when parents will bring them into hospital if they have one of these, because they're very frightening episodes. Even if they know that they have shaken the child, they will often bring them in at that point. So these things can come on immediately after shaking, and there can be a peak about 4 to 6 hours. Right, so what do we do if we think that a child has been physically abused? We're going to examine with the consent of the person with parent responsibility. We will write onto our paper form, and the consultant will then upload it to the Child Protection Shared Drive the next day. Now, for our paediatric middle grades, if we become aware of a case in A&E or that's going to be admitted to the ward, if it's during the evening, during the day, I would be ringing the consultant and saying, look, I've heard about this case, I'm going to go down and see them, because they may want to hang around and examine the child afterwards. But if a child is admitted during the night and they're clinically stable, so 2, 3 in the morning, I would be getting on to the consultant at around 7 the next morning to tell them, because they may want to come in first thing and assess the child. They will want to be seeing the child. We're going to draw on EPIC the body diagrams and any marks or bruises or injuries. We do record the shape, the size, and the colour. We're going to get a measuring tape out, and we're going to do photos. So if the police are called, they will do photos. At the minute in Antrim, we don't have a medical photographer, so you're going to be relying on yourselves taking the photos. Now, it's very easy to take photos on EPIC, either with the nurse's rover or on the Haiku app. But if you think this is a safeguarding issue and a physically abusive injury, then you should not be taking photos through that means. We have a system. If you have an iPad, either in ED or in Paediatric Unit or in Acorn or in Causeway, what you will do is take it on your iPad, and that can then be uploaded to Sectra and can be protected as a sensitive image. So it should not be on EPIC. EPIC was not designed to hold photos of abusive injuries. These will then be forming evidence of a police investigation, so they should not be on EPIC. We'll be doing our other bloods. There is a new guideline, especially for infants. We don't do as many investigations routinely as we used to do, and you can source that on the Child Protection Drive. We'll be doing x-rays. We may need neuroimaging. If we are doing infants and doing an MRI, we will end up MRIing their spine, as there's very characteristic changes on the upper cervical spine, musculature of abusive injury and shaking. You may have to get other opinions from plastic surgery, from hematology, from radiology, and we do so if we need to.